Great. And last but certainly not least, Dr. ALICIA Heapy, Associate Professor of Psychiatry at the Yale School of Medicine and Associate Director of the Pain Research, Informatics, Multimorbidities, and Education, or the Prime Center of Innovation at the VA Connecticut Healthcare System. ALICIA.
Good morning, everyone. So I'm going to be talking about technology-assisted care. These are my disclosures, none of which I think affect what I'm saying today. So just to set the stage, give you the parameters, I'm going to be talking about chronic rather than acute pain, pain in adults rather than children. I'm a psychologist, so I'll be focusing on psychological and behavioral interventions. And of course, there's no time to go into the details. I'm going to try to give you kind of some of the broad themes that I see in this area. So why should we use technology? In most areas, there's a lack of trained clinicians who can deliver these treatments to patients. Patients experience many barriers to accessing this care, like travel and scheduling limitations, as opposed to technology-delivered interventions that can be done in their home and at their convenience. Another issue is home-based care may not carry the stigma of other in-person care. Okay, so this slide is just used to highlight the diversity and the breadth of the different types of technologies that have been used to deliver self-management to patients. I certainly won't be talking about all of them. So, and even though this is a lengthy list, I'm sure I've missed several. There are also diverse interventions. I kind of think of them in two general buckets. The first bucket is theoretical interventions that have been adapted for the technology-based environment. These are things like CBT, ACT, mindfulness. Our strongest evidence lies in this area here, where we reliably see small to moderate effects. The second bucket is what I like to think of as modular treatment. So these treatments include many of the components that I've listed here, either singly or in combination. And those combinations are made in a theoretical, an evidence-based, and sometimes an ad hoc way. Superimposed on that, you see differences in terms of the amount of therapist contact that patients have. And these range anywhere from self-guided treatments that patients do on their own to asynchronous and synchronous treatment with clinicians. So I tried for a long time to think about the best way to summarize the evidence in this very broad area. And I'd say overall it's promising, but the limitations in the quality and the comparability of the studies really prevent us from answering these questions which McGuire laid out in a very pithy way. So what is the effectiveness of these interventions relative to in-person care? We don't know. We don't know which technologies are best. We don't know which treatments or treatment components are most important or effective. We don't understand to what extent therapist contact increases engagement and promotes outcome. And we don't know anything about the necessary frequency or intensity of that contact. So there have been many recommendations made for improving the quality here. I'll just highlight a few of them. Things like more RCTs and fewer single treatment arm studies. Really looking to increase comparability across the studies. I know a number of other speakers have noted the variability in treatments. Really focusing on those interventions that have a theoretical basis first, because our greatest evidence is there, and they are the easiest to replicate and adapt because we have a theory behind them. We presume that these treatments are less costly than in-person care, but we don't know that. No one has looked at the cost yet, and that needs to be done. And things like including clinical experts and end users and researchers in the development of these treatments tend to lead to better outcomes. And then the move to adapt these treatments for special or underserved populations such as older adults. So I want to talk a little bit about implementation. We really know very little about how to implement these treatments, either when going direct to the patient or when placing them within a health system as part of routine care. And so in order to get some clues for what we might be looking for going forward, we can look to other areas where technology-assisted interventions are farther along in the clinical and research pathway, such as internet interventions for anxiety and depression. So there's a recent study that came out examining the barriers and facilitators to successful implementation of iCBT for anxiety and depression in 5 national or regional health systems in the EU. And what they found is that there was a general agreement that there was a need for these technology-assisted interventions in order to increase access. There was, however, still skepticism, especially from referring providers, about the quality of these interventions. They found that they had to consistently use marketing and recruitment that was targeted at both providers and patients in order to maintain consistent referral rates. In many places, they augmented this with patient self-referral, which they seem to feel really helped get the most motivated patients into care more quickly. They had to adapt a little bit to fit with therapist training. So therapists are trained to deliver treatments in the in-person setting, and oftentimes they needed additional training to make that leap to the technology-based setting. And there were really 2 transition points where major adaptations had to occur, going from a research project to local clinical care, and then moving from local care to regional or national care. I'd like to say just a couple things about policy and guidance. So there are many questions in this realm. Who will pay for this, which is a huge one? How will we negotiate licensure issues when treating patients across state lines? These programs they cost money, of course, even when patients aren't in them. So you have to pay for hosting systems and information security and maintenance. We have to understand how to manage risk, how to screen and care for patients who may have suicidal behavior or ideation, and how we can intensify care if that's necessary with local resources. We have to understand how to protect patient data and maintain their safety in that way. There's really a need. Individual investigators are not able to do this alone. They really need to work in partnership with often commercial concerns that develop these technology-assisted treatments, the systems that the care will go into, and governmental agencies. So it's not a single-person sport, I guess I would say. And then another thing that's necessary, and we see in some of the literature where these treatments are more well-developed, is the use of consensus statements. So researchers coming together and deciding how to prevent reinventing the wheel and to work more effectively and efficiently together. Okay, so I think in summary, what I would say is not everyone who wants or could benefit from self-management interventions is able to get that in our current system. Technology could help us surmount that and get people more quickly into care and give them greater access, but barriers persist. An individual investigator acting alone cannot surmount those barriers. They need to work with others to develop consensus and to develop partnerships. I think I'll just take this opportunity to say that I think large integrated health systems like the VA, like the military health system, like Kaiser have a really important role to play here. These are systems that have a large expert workforce that knows how to develop, test, and implement treatments into care. It's located in a national infrastructure so that care can be distributed broadly amongst patients who typically need it quite a bit. But they have the backup of local systems, and it's all tied together with a common electronic health record system to really increase communication. So I think we should do it. We can do it. And I hope we will do it. Thank you.